even some of these rural hospitals, they're losing service lines. There was one just south of Indiana that just lost their OBGYN unit. And you think like a community losing their OB. I think we're massively missing the point. It's like we're trying to limit what the costs are. We talk a lot about health insurance, but we should be delivering health care.
Joining us, Area Senior Vice President of Consulting at Gallagher. Andrew's been at the forefront of the benefits and HR landscape, and today he's sharing the secret sauce behind Gallagher of Indiana's success, the biggest challenges that large employers face, and his bold predictions on where the market's headed. Would love to have our audience get to know you just a little bit. So you've been a vet in healthcare consulting. So I think you said over 20 years. Man, I'd love to start like how'd you get into the business?
So it's been 26 years. I actually got into business. Interesting. I went to school for hospital administration.
Okay.
So business and hospital administration, went to IU, which they're finally on the map for football. So that's good. Got out of school, did an extra semester just for the fun of it because I changed my major so many times. And then I wound up with like 3 different degrees, hospital administration, one of them. And then, long story short, I'm going to save you some of the boredom. I didn't do hospital administration, but I did live in a tent for a year in guided whitewater.
Huh.
I started, was at a desk doing all the stuff through, sales and some other work. I was like, it's got to be better. There's got to be something better. Then went out and just sold everything I had and lived in a tent for about a year.
Wow.
And then came back and got a job with Aetna. It was my first job back. And then that was probably in 1997.
Okay.
1997 and a half.
So started on the carrier side.
And then I worked in their small group. And then I realized, man, there's some help that can be done in this space. And then I opened up my own shop about 2.5 years into the business, doing small group, got licensed in investments, started doing 401ks, individual life insurance, group health benefits. Did that for 4 years, and then ran into some folks at Gallagher, and then they bought my block of business, and then I've been there 18 years.
Yeah.
Yep.
18 years,
18
and I can
years.
speak because I've interacted with your team, like one of the best teams in employee benefits consulting. So I think you've worked to build like an awesome unit of people and just, a team that loves working together and adds a lot of value to the clients you serve.
I appreciate you saying that because we've got, Mark and Christine I work very closely with, you know them. And I think you said in the beginning, secret sauce, it's the team, and it's people that care about each other and people that care about clients and that people care about learning and continuing to drive. I mean, I've been at Gallagher 18 years. My plan was 3 years. I'm like, I'll sell my business and then go do something else. Yeah. But it's learning every day, and then to be around the people that have that same thirst, because this business can.
So you had a 3-year earnout that's turned into 18, still
it's
going
18,
strong.
Yeah. I think I got the raw end of that deal somehow. But no, it's been, from a career perspective, one of the best things.
Yeah.
It's just, great organization. So I've been lucky enough to work with some great people, and we do a lot in the healthcare space. So work with a lot of hospitals, a lot of ortho groups, a lot of physician practices, health clinics across. So, I think that's about 80% of our business, which kind of goes in line with, my hospital administration degree. So everything kind of comes together. But we've, made quite a mark in that industry. And Gallagher just as a whole, I think, so from Indiana healthcare, we've probably got 3,500 people across the country that work in the healthcare vertical. So we've got quite a powerful team, a lot of thought leadership in that team. So just really excited to be part of that.
Yeah. I love you and Mark and Christine and that team. That's like, you guys are we call you guys the black belts of healthcare groups.
I love that.
Of just knowing what, because it's unique. When you work with healthcare groups, like The average knowledge of employees on general health care and health insurance is higher than most, which can be a great thing. It can also create some challenges when people know more of just sometimes like, man, just having to think through differently how you roll different things out to like nursing staff and these people who really understand how the system works. And from a clinical standpoint, they know more than the average layman. Would love to like for a second chat about like, how did you tell me about your first experience with ICHRA for a hospital, which I know was a couple years ago at this point.
You know, that's a good question. Just kind of like teeing that up a little bit. I think you mentioned kind of employee communication, weaving that in the healthcare space, and they know more. They're familiar with the delivery system. Yeah. The health insurance system that's driving it is a lot more confusing, and I think, it does in the healthcare space. There is more utilization. So like you look at a manufacturer and you look at a company that is a health provider, in a way, they understand that there's access here and there.
Yeah,
so
they use the plan because they know how to make it work for them because they're in the
So a lot of these costs are more so than the average employer, and it is complicated. And you talk about that, and I think these healthcare organizations, and the reason why we're so excited about it and working with Mark and Christine and just our healthcare vertical is, there's a lot of work to solve for them. It's a more complicated equation. And I think there's a disconnect on what the employees understand that full investment is and making that connection. It's what their premiums are and their deductibles are only just, a portion of that iceberg. There's a huge building size iceberg under there that the employer is subsidizing. So trying to connect those dots.
Yep.
Leading into your question then about, the first entree into the ICHRA space, which is fascinating. I think it's something that healthcare organizations need to explore that provide healthcare for, their domestic staff. So, we were working with an organization, not a large independent hospital, but one that was, you're always looking to solve problems. I'm looking at them as like, you're putting sandbags out to kind of keep the flood waters, at bay and keep costs in control for everybody. The entree to the ICHRA started. What's kind of fascinating about this is it starts because you've got an organization that has to comply with ACA regulations. I got to cover this. I've got to cover that. When you're working through renewals, it's and planning throughout the year, it's okay. Well, we want to cover that. We want to make sure that's taken care of. How do we find the right balance? How do we charge the right amount? But as you're working through that, you've got a population that you could have some kind of, a genetic gene therapy medication that needs to happen, or there's cancers there. The reinsurer doesn't have to insure them. They don't have to play by the same rules. So you're going to try to get stop loss, and you're like, we're going to cover all the claims up to $100,000. And the stop loss carrier says, okay, that's fine. Here's your premium, but oh yeah, that person that's really sick and that person that's really sick and that person over there that's got an upcoming surgery, we're going to laser them from the contract. So you could, at the end of the day, at 200, 300, fill in the blank on the size employer, but the smaller ones, when you get lasers, that could be like $2-3 million of extra exposure.
Yep.
So the entree to it is looking at what our exposure is. And I don't want to even get started about it. Drives me crazy that the employers have to, uphold the healthcare systems, but the people reinsuring them can cherry pick.
Yeah.
It's bananas.
Yep.
That doesn't happen in the individual
ACA,
health space.
That's one of the main problems it solves when they pass the ACA is it's guaranteed issue. So there is no cherry picking anymore in the individual health market, which there used to be pre-ACA.
Yeah.
That was underwriting, you could cherry pick. And that's one of the things that once a business leader learns and is reminded of the guaranteed issued nature of the individual market, if they've been running a self-funded plan forever where they're used to that stop-loss carrier being able to cherry pick. And it's almost like that you have to tell them twice before you're like, wait, you're telling me that there's no pre-existing conditions or past claims or specialty drugs impact the rates of people
on your ICHRA
on an
piece.
ICHRA
Right.
in the individual market. And you're like, yeah, that's what I said. That's what I meant. Yeah. And they're like, wow.
They're used to seeing, oh, I've got a 500,000 laser on this person. My exposure could be $1 million on this one, So talk about, the employers are propping up America's healthcare system, subsidizing Medicare and Medicaid. Give them a break, help them with that. What they do in return, so I say that, but they load it into premium. Oh, I don't want a laser. Okay, well, you're going to get that same $1 million, $2 million
in premium
thrown in premium.
Yep.
So, and an employer can't cherry pick on that. So, enter this healthcare organization. We were looking at everything. How do we keep the employee experience at a good level? How do we keep the cost down? We achieved, everything in this. It's interesting when I say everything. The employees' premiums were able to go down. They were able to customize their coverage. The employer could say, this is exactly how much it's going to cost me. Not okay, that's a good month in claims. Okay, that's double than what I expected. Okay, I'm back down here. Yeah. It just created some continuity for the CFO to budget, really.
Yep.
So it changed the game for that organization, and opened my eyes to like, okay, well, if they can work like this, it can work in other ways. And we've talked about this before, that it's for a healthcare system.
Yep.
What's the other benefit of that?
The other benefit, is so there's oftentimes, because these healthcare system workers are such high utilizers, there's premium savings moving to ICHRA and leveraging individual plans. But then there's a double benefit in that as long as your employees, which most in a hospital system do, as long as they continue to utilize the services provided by the hospital, we would call those domestic claims, that actually becomes revenue potential to the hospital, where now those individual carriers are reimbursing for those claims into the hospital, which is actual revenue in the door versus in a self-funded plan. I always say, and I think you say the same, it's like kind of in a self-funded plan, the left left pocket money goes in the right pocket money because it's the hospital kind of paying themselves.
Right.
In a sense.
It's like a restaurant giving their employees free food.
Right.
But there's still the cost associated with that.
Yep.
So it's, and we're still measuring some of what that is, just because it's all individual policies. And, I've chatted with a couple CFOs on it, and it's like, if they wrote off those claims, they're now having a third payer. It might be an Anthem United or an Ambetter or CareSource, fill in the blank. But what they were writing off now is actually revenue. And we've been partnering up, looking at some solutions to that, to help drive that domestic utilization, to help increase that and take care of the employees. Because I think what we've talked about, or at least you've kind of informed me about, is that the carriers are trying to match more of what these group plans look like.
Yep. So you saw Anthem this year in many states where we do a lot of work in Indiana. Like Anthem released ICHRA-specific off-exchange plans for the first time in 2026. Totally different network, different plan designs. The carriers are leaning in. So it was
matching that more so than...
Yep. Trying to match what traditional group plans, from a plan design perspective, trying to match that plan design with some of their off-ex plans.
I would have some questions for you because I think, for some of these, HR leaders, everybody's able to, in the group world, and it can get pretty, expensive in that for the healthcare space. We can also control costs. So, it's great to explore ICHRA on some things. I know some of the stumbling blocks for the organizations that we've worked with, and some that we've explored, is they can get on the phone and they can call our team. We can get on there and help, Jimmy and Susie and everything like that. It is different.
Yeah.
It's different for that. Maybe that HR person was a little more involved than they needed to. We don't need to coddle the employee as much. But I think that service model in the carrier space needs to evolve a little bit. And I'd just be curious on what you are seeing there.
100% agree. There's some leading carriers that I think have gotten out ahead of others where they actually have ICHRA specific teams that work with us as ICHRA administrators on specifically on like off exchange plans that they know are ICHRA enrollments. So I'd say a couple carriers that I think have been leading in having unique teams and how they work with ICHRA administrators on servicing those plans would be like Oscar Health. I think maybe does it better than most. Oscar's not a predominant Midwest carrier. They're actually more prevalent out East and West Coast, but they're growing. Yeah, I think they'll be in many Midwest states here by 2028, 2029. But then like the other one I would say is Ambetter. So like Ambetter's got a team of people just dedicated to service the ICHRA off-exchange plans and work with Remodel Health and the other ICHRA administrators that are out there to try to improve that service level that these employees are used to having. I think different and honestly better service.
It's immediate.
It's immediate.
Yeah, it's immediate on the group stuff. You can be like, reach out to us and then you've got an answer in 2 hours.
Yep.
It's been different. In the ICHRA space a little bit.
So that kind of actually dovetails and wants me to kind of go in a little bit of a separate vein for a second. So one of the things that like we're always keeping tabs on is our executive leadership team is we're looking at legislation and like what can ICHRA administrators do to lobby together to advocate for legislative change that benefits everybody in this ICHRA ecosystem. I was actually, believe it or not, just in DC Sunday and Monday this week. Do not recommend going to DC in a snowstorm. Flight got canceled. Had to drive 10 hours. I didn't even get a fly. Had to drive 10 hours to DC on Sunday morning. Crazy. Drove back because all the flights were canceled. Couldn't rebook, but I wanted to get out there for this conference I've been at now twice in a row. It's the NABIP Capital Conference. And a big part of that is kind of legislation. So like legislatively specific, something I think is very interesting for a lot of these hospitals that we've taken a look at, like general healthcare legislation, even state to state, I think has accelerated the adoption of ICHRA across hospitals because like in Indiana, I'll speak to specifically, legislation's kind of happened where they're going to not be able to charge what they've charged historically on the commercial insurance side. So hospitals are kind of being squeezed from a revenue standpoint. And with revenue going down, you've got CFOs looking for, okay, what are ways that we can be creative from a budgetary standpoint to save dollars when we're not allowed to kind of bill what we were allowed to bill going forward. Yeah,
I think like House Bill 1004 is one of those. And, this is a spot that, I think it's just debatable in any way because some people are like, oh, these hospitals are making so much money and this and that. That's not actually, you and I have talked about this. I mean, to keep doctors and nurses and the equipment that's so expensive and everything that they're dealing with. You said, the legislation is squeezing their reimbursements. The carrier market is squeezing their reimbursements. There's some carriers that pay, Medicare is, everybody is a much lower rate. They're not making money on Medicare, some of these independent hospitals and these rural hospitals, but and then you've got carriers that are reimbursing them at like 100 and 105%, so 5% over Medicare for professional services.
Right.
And I'll just say, like my wife's a therapist, so she used to take insurance, but I'm not going to throw any carrier under the bus here, but she just stopped, I'm not taking that anymore. I'm not taking that insurance anymore. But when you think about it, like she would be doing group therapy. She's, a professional. She's, got her master's, licensed clinical, therapist and everything. So I think her rates just kept going down and down and down. So the next thing you know, she's doing a couple, helping them with an hour of, mental health and saving marriages. And I think it was like $72 to work with a couple for an hour.
Yeah.
And I'm like, I was like, you can make more. Like doing a massage or, a massage therapist is making more than somebody with, 8 years of schooling.
Yep.
And it's nothing against any profession, but when you've got that reimbursement pressure coming in at the government level, the carrier level, dictating what you can make.
Yep.
you got to get creative.
100%. Like they're, I feel like, yeah, the hospitals get the bad rap, but it's all of the ecosystem of vendors that serve in the healthcare world.
Yeah.
Like a lot of them are hidden where they don't get a bad rap. I remember my father-in-law, he's since passed, but he was a diabetic, struggled with diabetes for years and years and years. And he, anytime he had a wound, those wounds had a hard time healing.
Yeah.
And he had to have a special bed for these bed sores that he had because he was in the hospital for a really, really long time. And I remember the doctor telling us, you know what this bed costs? Special bed made by Hillrom, so a manufacturer in Indiana, $1 million for one bed that was built just to help people that have bed sores. And like nobody thinks about kind of the Hillrom manufacturer of, and they're doing great work creating a bed that's going to help bed sores heal. But like those are the types of costs that I think oftentimes get missed when people think about the cost of healthcare. They just think straight to the providers in the hospital. It's like, man, no, there's this whole ecosystem that's create the equipment, I feel like that's something you can tell I get passionate about it.
I mean, you're exactly right. And we spent some time chatting with the CFO, and he was just like, I mean, the education debt that these providers walk out with. I mean, that's massive.
Yep.
And then trying to recruit people. I mean, you've got even some of these rural hospitals, they're losing service lines. There was one just south of Indiana that just lost their OBGYN. And you think like a community losing their OB. I think we're massively missing the point. It's like we're trying to limit what the costs are. We talk a lot about health insurance, but we should be delivering health care. And we've got independent hospitals, we've got physician practices, independent practice, all these. We've got the perfect setup to do it, but we're squashing the creativeness, the innovative, and the ability for them to make a living and have providers that want to go to a smaller southern town in Indiana or northern Indiana. We're missing the mark, and I hope we get it intact.
I'm with you. Like the thing, like why I've been at Remodel 2.5 years. So I come from the self-funded analytics space. Like that was my background.
Yeah.
So ICHRA on the risk spectrum, total opposite of self-funding.
Yeah.
Why I get so excited about ICHRA in the future is a couple things. Number one, and we talked about like the stop loss lasering problem 10 minutes ago in our conversation, is ICHRA solves for that because you've got a really big risk pool. So like the ACA risk pool is over 20 million people. Mm-hmm. So you've got insurance is all law of large numbers at the end of the day. If you have a bigger risk pool, the risk is easier to manage, more predictable. So it solves kind of the problem of a smaller 200-300 person hospital. Their risk pool is not big enough where a couple bad things happen, you're left scrambling. Stop loss carrier can put a laser on a few people, and it's like, man, I can't handle that exposure. Yeah. So it solves I think the risk pool size problem. But then what I'm most excited about is I think it actually is going to drive innovation faster because you've got carriers competing for the individual business.
Yeah.
So all these carriers, so in Indiana, you've got Ambetter, you've got Anthem, you've got United Healthcare, you've got Cigna, you've got all these carriers that are now competing for the individual people to enroll and pick their plan.
Yeah.
I think it's going to, like, as the ICHRA continues to grow, that competition is going to heat up. The end employee is going to become a better consumer when they go into year 2 of their ICHRA open enrollment, year 3 of their ICHRA open enrollment. So it's actually attacking the problem in a unique way that's not really been able to be attacked before.
I hope I like to believe that's the case, that they are going to be competing for business. But what happens when you compete for business? Prices need to be, they're driving down the rates.
Yep. Well, you can drive down rates in 2 ways. You either like narrow network and you don't pay the providers what they need to make, or you manage your risk pool the best, where you've got the highest quality network. And that's what I think, like all these carriers, man, they're really fine tuning, like what does their individual plan network look like, where they've got the highest quality providers that are going to deliver the best care, which should result in the lowest amount of claims long term.
Yeah, there's 2 things in that, and I think some of those individual carriers, they are trying to come in there and renegotiate the prices with the providers and trying to drive that down. But I like your comment on getting in there and managing that population. So I'd be curious on how they do that. effectively, and how they get more involved with, because you said, more narrow network and driving to, high quality, lower cost providers. That's what we all want. Which is also fascinating because sometimes you look at these larger carriers and it's like, PPO stands for Preferred Provider Organization, but what's preferred about it if everybody's provider's in it?
Yeah. Yep.
And then it's like, do you really need a net? I'm a big believer in direct primary care. Yep. And pick a horse, pick a hospital system and drive your tertiary care there. Pick a local partner, independent hospital, and get your care there.
Yeah.
Keep it in Indiana and keep it local. You don't need a network that's got 7,000. Mean, it's bananas.
I 100% agree.
Yeah.
The other thing I love, and this is me geeking out again from my self-funded days, is a big self-funded plan that's got enough of a population in a certain area, they can justify an on-site or a near-site clinic model or a direct primary care agreement where they're making primary care super easy for their employees to access at their work environment. Yep. The thing I like about ICHRA is as ICHRA pockets of population grow, the carriers are going to have enough members in a rating area, which in the individual market, a rating area is typically a county or a couple counties. They're going to have enough bodies that are insured in those rating areas to start to develop really innovative, I think, like near site direct primary care model offered through the insurance carrier. Really? So like we saw that for the first time this year in Des Moines, Iowa. So not an Indiana example, but in Iowa, ICHRA Health did a partnership with Hy-Vee.
Okay.
The grocery store that's big time out in that and pharmacy
clinic,
and they've got like these plans now that are like steering care, but it's like almost like a near site clinic model. Yeah. Provides $0 care for many different things through Hy-Vee in kind of the ICHRA model where people live. So it improves their access to care and reduces the friction to get that type of care done. Get ready for AIM 2026, the premier and largest ICHRA conference in the nation. Join us May 20th through the 22nd, 2026 at the JW Marriott in Indianapolis. Over 3 days, you'll hear from industry leaders, gaining real actionable insights on market trends and strategy, and be able to connect with the nation's leading brokers, carriers, employers, and industry innovators who are driving the ICHRA movement forward. Head to remodelhealth.com/AIM 2026 to register. And use the discount code ICHRA exclusive for 25% off your registration. One of the things we're seeing that we've seen together and working together last over a year now is that ICHRA is not just being evaluated by hospitals of 200, 300, 400. This thing's starting to go up market where we're routinely running through feasibility analysis and looking at this thing for hospitals that have multi-thousands of employees. So it's definitely moving up market. And I would say the cost savings can be there for those organizations as well. I mean, it's not uncommon for us to see a $7,000, $8,000, $9,000 PEPY cost savings for some of these hospitals that their self-funded plan has just gotten so expensive over time. Yeah. So would love to hear kind of your thoughts on this thing moving up market as well.
And I think, and you're absolutely right. If you can save, a couple $1 million for a, 200-300 life group, you can save, what is that, $5, $6, $7 million.
Those numbers get real fun to look at the bigger you get.
It's very exciting to look at. So you're absolutely right. The same challenges on the smaller group are happening. I say smaller group on the 200-300. Same stuff that we're dealing with from a reinsurance perspective on the larger ones. And to kind of further that point, I think that savings are great. We want to take care of the employees. I mean that's the big thing. Is everybody's wanting to achieve better health outcomes. We're wanting to enhance the employee experience, and we're wanting to reduce costs. That's kind of like you run it through those three things, and you can do that in the ICHRA space very effectively.
Yep.
So,
yeah, and talk to me. I think too the bigger an employer gets, I'm big on like, okay, the bigger the employer, the more runway you need to like navigate the change that is moving to ICHRA, where like I know the Gallagher team does an incredible job in collaboration with us as the ICHRA admin, but also the HR team at the employer, and figuring out, okay, what does a 5 or 6 month runway look like so that we can do the education very well across the employee base, so people feel like they're going in eyes wide open to what is ICHRA, what's this change going to look like, how's this going to be different for me and my family. So would love to hear kind of your thoughts on, because I know you guys have worked with, in collaboration with us for many, worked with some of these larger hospitals and healthcare entities that have made the shift. What are some best practices for large organizations making the shift to ICHRA?
It is a good point. You need plenty of runway on this stuff, and it's not really from an education on employees, because as we've been kind of finding that sweet spot together too, it's like, when do you bring the employees into the conversation? You don't want to, you want to do it where it makes sense on that. But backing up, we're starting the analysis now for groups that may not have done it last year, that kicked the tires. So that runway is a little bit smaller, but you've got to bring managers in. So one, it's board meetings. You're meeting the board, you're sharing that information, but the first beyond that is, okay, HR, CFO, CEO, meeting with the board. And then it's, okay, we're going to move forward in this. Then it's manager meetings, and we've done little focus groups, putting the whole thing together, getting everybody in a room. And we've done some stuff where we're just looking at, hey, let's get everybody in a room and do some premium modeling and show them what their choices are and what the cost would be. And people are like, wait, I can choose a plan with no premium. And these are managers, so you don't want to just, you got to pull them in, because when somebody's not happy with something, they go to their manager.
They're going to go to their manager.
Right. So the managers have to be in. So it's, all the way from the top has to be excited about this and bought in. And that's where it's successful. If people aren't bought in from the top, you're going to be going down a path, and it's not going to be a good one.
Right. No, and I think that's such a good point. Like, taking the time to help employees understand, okay, moving to ICHRA, like some employees, you just got a $3,000 raise, where now the cost out of your pocket many times is significantly less for the employee contribution each month. So that then when you're a couple months in, like, ICHRA's not all roses, like there can be bumps, but I think with any alternative type health plan, so I could say the same for reference-based pricing. There's friction that happens when you shift from a traditional like PPO style group plan to anything alternative. That could be reference-based, that could be ICHRA. Like, sometimes reminding employees of, hey, like, you're saving this amount of money. Yeah, there's going to be a little bit of bumps along the way, but it's still worth it. And you got to pick a good ICHRA partner that's going to help navigate through and work through those bumps to continue to deliver a good employee experience. But that's something I'm huge on, because like I always say, man, if you're expecting to lose weight, you're not going to lose weight unless you change your diet and you start working out more. Like, same is true in alternative health plan. There's going to be some trade-offs where you just have to change, and you get through that friction to get kind of the reward that we're going after.
It's, you squeeze the balloon this way, something's going to happen on the other side. But you bring up reference-based pricing too, and it's like, I work with many organizations that have, we've done a lot of reference-based pricing, and ICHRA. And then for some, I'm just like, for some of this, I'd rather see you guys on an ICHRA arrangement. It's just, when you talk about employee experience, it's 4% of the people are driving 60% of the costs on here. So it's like, when you look at where the bulk of that 90% of the membership is, how can we create a really good experience for them, and then make sure that those 4% of the members driving have access to quality care. They don't have to worry about, it's confusing getting your EOBs, getting your bills from the providers, and then you get a bill, then you get another one later that it's less or more than that. You're like, well, which one do I pay? It's, but you talked about one, which is a really good point on some of this, is the raise that an employee gets. And some of these recent ones, we've gone through together, we've looked at some of this. It was like, one healthcare organization was like $312 as an average premium, and it was $120 under the ICHRA.
For the employee contribution.
For the employee contribution.
Almost $200 savings per employee. That's
Yeah.
monthly times 12. That's $2,400.
Yeah, on
back
some of
in
these, you're putting $1.5 million back in the employee, bank accounts.
Yep.
Another one was in the same. It was like 296 or something. Oh, 220, and then their employee 220 under the group plan, 96 average under the ICHRA. With many people choosing a plan.
Yep.
That blew me away when I was first looking at this. Is like, well, they can. We talked about the 90% that aren't really, they might have some claims here and there, some medications, but for those people to buy a plan that fits them, that's pretty powerful.
Yep. Yeah, for sure. Yeah, like I Remodel's on an ICHRA. Our family went through this year, and like for the Witham family, I've got 2 boys and a wife, and I mean, praise the Lord, we have no health conditions going on. So like we don't have any expected, like I've got 2 boys that are crazy that are probably breaking arm this year again, but nothing that I know is going to happen. So like for our family, it made sense to get a bronze plan that's HSA eligible. Actually, that's also got copay. So for the first time, the bronze plans have copay style and HSA eligible. So like we're able to take advantage of the HSA kind of benefits. And like we're willing to get less cost coming out of my pay every month, and kind of take that risk of having but that's the kind of choice that employees have access to. Is if you're not a high utilizer, you don't have any expected claim, like you can buy down to a less rich plan in the ICHRA model to maximize kind of your income and not have as much come out of your pay.
Yeah, I another fascinating kind of, we talk about the savings for employees. And not to wave the ICHRA flag over here, but we do have other health providers, that have, independent physician practices. And these are like, 2,000 employees. They're looking at it just, can I get out of the game?
Yep.
Because, the time we spend and invest, what are we doing on your pharmacy? Okay. What formula are we going to set up? How are we going to cover specialty drugs? Well, okay, that's getting really expensive. How do we source them differently? I mean, it is a massive game of whack-a-mole. Okay, The GLP-1s are coming up. Okay, how do we try to carve those out? And then the manufacturers say, oh, well, if you carve that out, then you're not getting your rebate. I mean, the game is not rigged for the employer's benefit. So it is a constant game of whack-a-mole. So they're like, hey, even if I move to an ICHRA and I spend the same, but I don't have to invest in a whole staff to manage these health plan decisions. Yeah. And we can focus on communication and just shift that time into other employee-focused arenas.
Yeah.
That's another area that we don't talk about a lot.
Yeah. One exciting opportunity coming up, Andrew, while we had you in here today, wanted to have you just share a little bit about the Indiana Healthcare Forum that's coming up March 12th. So not too far from when this will be published.
Yeah, March 12th. Yeah, so this might be after we have the event, but it's already getting some great traction. So the Indiana Healthcare Leadership Forum, I mentioned our healthcare vertical. So we've got our leader that leads that vertical within Gallagher coming. We've got tons of industry information, what's happening, just with legislation. We were talking about that. A lot of employee experience, a lot of comp in the healthcare space, like what's happening with comp. So we've got a lot of information. We've partnered up with our friends at the Indiana Hospital Association and the Suburban Health Organization. So
Awesome.
we're doing it at the Indianapolis Motor Speedway.
Yeah.
So we're going to be in, I think, one of the media rooms there, but we've got a lot of people signing up. We're going to do some museum tours afterwards. They did a whole renovation there, so it should be pretty exciting. A lot of good thought leadership.
Love that. Yeah, if you're in the healthcare segment, especially in the Midwest, like put that on your calendar. I do think our team publishes these quick, so I would expect that it will be published before March 12th, Indiana Healthcare Leaders Forum. So that's awesome.
Yep.
Hey, man, to end our time, I like to ask the same question to every guest that we have.
Oh gosh, I should have watched the episode. Sarah sent me the episodes I didn't watch.
So you say you've got a magic wand, you can wave it. We're thinking 5 years from now. What's the one thing you hope changes in the ICHRA landscape as we look at like this in 2030?
Oh gosh, I was hoping you wouldn't narrow if I've got a magic wand, I would magic wand not to have to be limited on what I choose to use it on, maybe. So I would want email to disappear forever.
What email to disappear?
Yeah, I mean, it's, no, but all kidding aside, in the ICHRA space, what would I want if I had a magic wand and I would wave it over? Well, I just hope in 5 years that this would already be solved. But we talked a little bit about the service model on that, and I think that, gosh, I would hope that the rates, that we don't go through all of this stuff with, the subsidies are going away, and then the rates increase, but then the subsidies stay. Well, then shouldn't the rates go down? I say let's look at things with common sense.
Yeah.
Take care of the employees and take care of our local health providers. If they're teaming up, like Oscars, Ambetters, team up with the local providers that the infrastructure's already there and figure out a way to partner up that way.
Yep.
That's my magic wish.
Love that.
That's the genie.
Yeah, that's great.
Yeah.
Well, man, this has been a treat. Thanks so much
I've
for joining
enjoyed
us,
it.
Andrew, man. I enjoyed it. Like you and I feel like we could just riff, and
Yeah,
I don't even want to stop.
yeah.
I don't even want to stop this conversation.
I wouldn't have known what was going on if this microphone wasn't in front of my face. But everybody, you guys have been great. Sarah brought me some protein because I hadn't had lunch yet. So this has been awesome.
Yeah.
And Mark's been great over there. Yeah.
Yeah,
He's sitting in the sun.
we just get to be the faces of this thing, man. But the hard work really goes on.
Yeah.
Sarah and Mark and just all the marketing team at Remodel that makes this happen. But thanks for joining us, man.
Yep. Thanks, everybody.